our own state. And unfortunately, it's by Zoom, but we were feeling here as at home because we have a large display. So again, it's Friday, 8:30. Let's roll vision research and see what is new there. We will start with introduction of our speaker.
Good morning, everyone. It's an absolute pleasure to welcome you all to the weekly Distinguished Speaker Series hosted by the Center for Translational Vision Research. Today, we have the privilege of hearing from an accomplished researcher who has made remarkable contributions to the field of vision science. I am Prakatishwari Gopalakrishnan, also known as Pradi, postdoc in Dr. Zode's lab, and it is my distinct honor to introduce today's speaker, Dr. Glenn Yu, Professor of Ophthalmology at UC Davis Eye Center. Dr. Yu's academic journey began with a BA in Biochemistry and Psychology from Columbia University, followed by a PhD in Neurobiology and an MD from Harvard Medical School. He continued his medical training with an internship in internal medicine at Brigham and Women's Hospital and a residency in ophthalmology at Mass Eye and Ear Infirmary. He further specialized with a fellowship in vitreoretinal surgery at Duke University Medical Center. As a distinguished clinician scientist and board certified retinal specialist, Dr. Yu combines his clinical expertise with pioneering research in retinal diseases, particularly age-related macular degeneration. His innovative work includes being the first to utilize CRISPR-Cas9 genome editing to suppress VEGF for neovascular AMD treatment and advancing the suprachoroidal delivery of AAV for retinal gene therapy. Furthermore, his research also extends to multimodal retinal imaging in non-human primates to study aging and drusen phenotype for dry AMD. Beyond his research, Dr. Yu serves as a director of UC Davis Reading Center and director of teleophthalmology, where he has advanced telemedicine initiatives such as remote diabetic eye screening programs to improve patient access and care. Dr. Yu's impactful research portfolio includes 10 active and recently completed grants and over 130 peer-reviewed publications, with thousands of citations reflecting his profound contribution to the field. He has received numerous awards, including Orvo Carroll Camrus Translational Research Award, UC Davis Academic Senate Distinguished Scholar Public Service Award, and the American Academy of Ophthalmology Achievement Award. With that introduction, please join me in warmly welcoming Dr. Glenn Yu to deliver his talk titled Gene Therapy and Genome Editing for Age-Related Macular Degeneration.
Thank you. I hope everyone can hear me. So today, thank you for that really wonderful introduction. It was actually scary when you listen to you go through all my training. I was like, man, I was in school for a long time. But as you know, because I'm a clinician scientist, obviously that's a lot of the training. But I also, so currently I'm a professor at the University of California in Davis. And I spend still about a third of my time seeing patients and doing surgeries on patients with retinal diseases, and about 2/3 of my time in the lab. And being at UC Davis, one of the great advantages is that we're one of two campuses that have a primate center, a very world-class veterinary school, as well as a medical school on the same campus. And that has really kind of informed the direction of my research, where today I will kind of summarize a lot of our work, ranging from work in clinical trials all the way to more translational work in non-human primates in the area of AMD and gene therapy. Here are my financial disclosures. Of note, the ones in bold are relevant to this discussion, primarily in gene therapy companies. So what exactly is gene therapy? The simplest term is that you are delivering a gene, usually using some type of delivery vector, into a patient. And in doing so, you need to usually have a gene to identify, you need to have a vector to deliver it, and you have to have a delivery mode. Now, typically with most inherited retinal diseases, especially single gene disorders, you kind of know, at least for gene augmentation therapy, you know what gene you're delivering. Now, in terms of vectors, generally there are different ways you can deliver a gene. Factors that you prefer would be something with high expression, long duration, large capacity, low immunogenicity, and a low risk of mutations. Now, things like a lentivirus actually checks off most of those boxes. However, lentiviruses actually integrate into the genome, and as a result, potentially could be mutagenic. AAV actually does not integrate. However, it has a limited capacity. So larger genes like the ABCA4 gene can potentially is more difficult to deliver using AAV, although there's strategies to overcome that. Adenoviruses have largely been abandoned, mainly because it was causing a lot of uveitis. And synthetic vectors generally are much safer, but they also don't work very well. And so most of the efforts are really trying to get them to have higher expression. Once you've identified your vector, then you have to deliver it to the eyeball in some way. And the typical ways are either an intravitreal injection, where you just inject it into the middle of the eye, or a subretinal injection. Now, a subretinal injection is nice because it gets those viral particles right up against those photoreceptors and RPE cells, which is typically where you want to get the viral particles. But the therapeutic effect is usually limited to just the area of the subretinal bleb. Now, with intravitreal AAV, it turns out that AAV typically cannot, at least native serotypes of AAV, cannot penetrate through the internal limiting membrane, which creates a barrier between to access the retina itself. And also intravitreal injections obviously are still preferred because it's something you can do in the clinical setting, whereas subretinal injections often require complex vitreoretinal surgery to access the subretinal space. Now, once you've identified one of each, you can essentially develop a new therapy, and that really was what led to the FDA approval of the first gene therapy in the eye, which is for RPE65, using an AAV with subretinal injection. The strategy was to you essentially put the AAV in a 1 cc syringe, you connect it to a subretinal cannula, you do a vitrectomy surgery, and then you use that very thin 41 gauge needle to inject it into the subretinal space. And using intraoperative OCT being optical coherence tomography, using this live imaging, you can see the bleb being created by the subretinals in the subretinal space. In the early clinical trials, it actually was very successful. They used this new method of what's called multi-luminance mobility tests, which allowed us to actually measure people with low vision, their performance. And they showed that with the gene therapy, people were able to get through this maze much more quickly. And they even showed about 8-letter gain in terms of vision. Now, doesn't come without cost. So it seems like subretinal injections, these are intraoperative photographs showing that bleb right after they do the injection. And it turns out that after about even a month, you can start seeing these evidence of what's called chororetinal atrophy. So there's essentially atrophic changes, mostly to the photoreceptors into the outer retina, along those areas at the edges of the bleb. And they also evidence that there could be subretinal deposits, kind of deposits underneath the retina. And the mechanism of this is not very clear, although I will address this later in my talk. Now, we typically think about gene therapy really for the treatment of inherited retinal diseases like single gene disorders. But can you treat complex diseases, the topic of our talk today, with like AMD, where it's a degenerative condition with many genes interacting with environmental factors? The other difference is that when you're talking about inherited diseases, usually you're talking about younger people, often children, and the therapeutic benefit extends for their entire lifetime, whereas for patients who might be older, particularly those with AMD, that therapeutic effect may not give them as big of a benefit or at least as much time. But one gene that is very common to most of these complex diseases is VEGF. Now, AMD, as you know, begins with the presence of drusen, which are these sub-RPE deposits of lipids and proteins. And in more advanced stages, you can develop choroidal neovascularization. Often we call it wet AMD because it's a process of angiogenesis, versus more of a dry degenerative process known as geographic or macular atrophy. Currently, we can treat both of these conditions, although it's much more effective with wet AMD, where we're injecting anti-VEGF agents agents that block angiogenesis versus in geographic atrophy, currently we're treating with complement inhibitors that only can slow down the rate of progression by a very marginal amount of time. What's the advantage of injecting a gene therapy instead of a drug? When you inject an anti-VEGF agent, much of the drug is concentrated in the vitreous humor, and a lot of it actually exits through the aqueous, and only a small amount of it gets into the retina. At the same time, you look at the upper right, the pharmacokinetics is very pulsatile, right? You have these really high doses, super therapeutic levels of drug, and then it kind of goes down over time, and then you have to give them another large bolus. Whereas theoretically, if a gene therapy is delivered appropriately to the retina and choroid, then the drug would be highest, if given as a biofactory approach, highest in the retina and choroid, and the pharmacokinetics would be much more steady state. So that was the strategy behind the AbbVie's RGX-314 program, where essentially it's an AAV8 that includes an anti-VEGF Fab fragment similar to aflibercept, which we give in patients. And in long-term extension of their phase 2 trials, actually, you can see some patients are gone out to year 4. And interestingly, they're retaining their visual acuity, whereas in real-world settings, if you look below here, these are just real-world studies or long-term extension of clinical trial patients that are done with their clinical trial. Almost all of them lose vision over time, and we hypothesize that it's mostly due to attrition with follow-up because it's hard for patients to come back month after month to get these injections. So they skip an injection here, they space out the injection, so they miss an appointment, and they slowly lose vision over time. In the RGX-214 program, you can see here at 0, that's each of these lines is a single patient. Each of these dots is a single visit, and the filled dots are an actual injection. So you can see many of these patients required almost 10 or more injections before the treatment. But after a single treatment, you can see that a large percentage of these patients can become either injection-free or at least need very few rescue injections. Now, that was a subretinal injection program. There are also intravitreal development being done. So, for example, AAVs have been developed through a process known as directed evolution, where you take libraries of AAV with small capsid mutations and you inject it into an eye intravitreally, and then you do multiple cycles of selection for photoreceptors or whatever cell type that got transduced. And that was how that led to the development of the AAV7M8 vector by John Flannery's lab back in 2013. And this vector has now been taken into clinical trials to deliver aflibercept. And this is their study essentially showing that, again, patients who previously needed 10 or more injections after a single dose of this gene therapy, especially at the higher dose on top, you can see that many of the patients can become injection-free. Now, one issue, however, is that some of these patients also develop inflammation. So if you look at the upper left here, these are patients at the highest dose of this gene therapy, and you can see many of these patients develop at least 3 to 4 plus of cell, which is how we grade inflammation in the clinical setting. And they even developed hypotony to the point where the study had to be terminated because people were going blind from this gene therapy. Now, if you look at the hypotony, however, that the effect seems to be disease dependent. So in the diabetic macular edema trial, there was a lot more inflammation and didn't see that effect in patients with AMD. And so those trials are actually going to phase 3 testing now. Now, why do patients develop inflammation? We thought that the eyeball has ocular immune privilege. So I'm going to take a few minutes to give some background on just ocular immune privilege and the role of inflammation in the eye. Generally, the eye is considered immune privileged partially because the inside of the eye lack lymphatic drainage. So that would be like the vitreous, the retina, and the subretinal space, whereas the outside of the eye, like the conjunctiva, the sclera, and the choroid, has lymphatics. Additionally, there are blood ocular barriers, like what we call the blood-brain barrier, and that outer barrier has a generally immunosuppressive environment with expression of immunoinhibitory molecules like TGF-beta. And then finally, there's this concept of immune deviation, similar to what's called anterior chamber associated immune deviation, or ACADE, which is a process by which ocular antigens introduced into the anterior chamber actually triggers immune suppression through immunomodulatory T cells. And that effect is what allows us to actually do corneal transplants. And a similar effect is also present in the vitreous or in the retina. Now, in the early studies from Paul Sieving at the NIH, looking at AAV8 to transduce to treat patients with X-linked retinoschisis, turns out that people with X-linked retinoschisis probably have a compromised internal limiting membrane, so they actually could just be treated with regular AAV8 expressing the retinoschisin gene. And they did a dose escalation phase 1/2 study, and you can see at the higher doses that you actually can see collapse of those schisis cavities on the bottom left-hand side here. However, they also saw a dose-dependent escalation in inflammation, as you can see here with inflammation seen particularly in the 1E11 viral genomes per eye. And what was interesting is that if you look at actually a kind of a dirty indicator of the inflammatory status of the patient, we actually find that the patients, even before gene therapy, already have some pro-inflammatory effect. So if you look at like the CD4 to CD8 ratio and look at the bottom left here, it turns out this is all before gene therapy, that many of these patients actually had an elevated CD4 to CD8 ratio even before treatment, and that ratio is associated with higher inflammation. So it's almost as after gene therapy. So it's almost as if these patients with retinal diseases may have compromised blood retinal barriers, leading to a more pro-inflammatory status to begin with, and then they get revved up even more when they get exposed to a viral vector. Now, the other effect has to do with the mode of delivery. We talked earlier about either intravitreal versus subretinal, and this is actually a nice review back in 2020 that looked across both large animal studies as well as human studies. And the green is showing no inflammation, whereas the orange and blue are either systemic or ocular inflammation. And you can see for any single dose, intravitreal injections generally lead to higher levels of inflammation, or higher levels of inflammation even at lower dose, suggesting that the subretinal space is a little bit more immune privileged or less prone to inflammation. So that has led to people trying to do more directed evolution and trying to develop better AAVs that can be given intravitreally, but just trying to achieve it at a lower dose. So for example, whereas the 7M8 vector was actually done by directed evolution in mice, this R100 capsid, which is actually unpublished, it's proprietary from 4DMT, shows that they actually did directed evolution in non-human primates and was able to get much better in vivo transduction in monkeys as you can see in the bottom right-hand corner here. And that has led to the development of this 4D150 platform, which is using this R100 vector capsid to deliver both an anti-VEGF agent as well as a VEGF-C RNAi. And in early clinical trials, that also shows that it could be effective at slightly lower doses than what's been reported by Adverum, and also lower levels of inflammation. Now, I'm going to take a side note back to when I was a fellow. So one of the things that I did when I was a fellow, and it's hard to get into the lab as a clinician in training at the time, but one thing we were doing a lot of was ocular imaging. And we always knew that there was something called what's called the suprachoroidal space, which we always describe as a potential space that only is present in pathologic conditions. So this is actually a patient undergoing ultrasound with what we call the T sign, because he has posterior scleritis, or inflammation of the sclera. But when we start looking at just normal patients on OCT, we actually find that in some patients, you can see actually that suprachoroidal space as well. And in fact, we did some studies looking at the thickness of that space. We actually find that we can see that space in half of the patients we examined. These are just normal patients. And that there was actually a distinction in in the refractive error, suggesting that mostly people who have a visible suprachoroidal layer tend to be more hyperopic. And in fact, that thickness of that layer is higher when the patients are even more hyperopic, which led me to hypothesize that perhaps usually there's a normal egress of choroidal proteins through the sclera, kind of oozing into the periorbital space. And that in patients who are hyperopic, they tend to have a more, their eyes are smaller, they have a more compact scleral architecture, that perhaps that there could be kind of impaired egress of those proteins, leading to an osmotic expansion of the suprachoroidal layer, allowing there to be a little bit of physiologic fluid presence in the suprachoroidal space, even in normal patients. This space actually turned out to be accessible for drug delivery, and the two general ways to do it is either with a microneedle, which are just very, very short needles that are just long enough to penetrate the sclera without perforating in through the retina. And the idea is that then you can deliver a drug into the suprachoroidal space, or you can do it surgically by microcatheterization. And the reason why I brought this up is that, oh yeah, so you can see also that this is just another way of showing how when you do a suprachoroidal injection with a microneedle, you can actually see that drug kind of stay confined to the wall of the eye. And that really can increase the dose of delivery because it's not kind of diffusing everywhere. And it potentially could concentrate it better in the posterior pole of the eyeball. The second thing that we also notice is that there's actually differences in the durability based on the particle size. So just remember the choroid is a high flow structure. It actually has the highest blood flow of any organ in the body, 4 times higher than the kidneys and 10 times higher than the brain. And so when you just inject, let's say, BSS or salt or PBS or some kind of saline solution, it just gets washed out very quickly. So it actually benefits from having larger particles that can stay in the suprachoroidal space for longer. And in fact, early studies involving triamcinolone, so that's a steroid, and we're using steroids because steroid is formulated usually as a suspension. They're kind of like little clumps of steroid suspension. You can see on anterior segment OCT that it actually can create a space, and we can actually even see it on posterior segment OCT, where we did segmentation, where we kind of traced that space and showed that only in the patients that had a visible suprachoroidal space and and received the actual suprachoroidal triamcinolone showed an expansion of that suprachoroidal space in real time. So I brought all this up because one of the things I thought about when I first actually became a faculty, I'm like a freshly finished all my schooling. I thought about the potential of injecting or delivering a gene therapy through the suprachoroidal space. And when I looked in literature, there was a paper published in 2011 by Peden et al. That showed that they were able to successfully do that in a single rabbit or in a few rabbits. The images weren't really clear. Exactly how they did that suprachoroidal injection was also not very clear. They did use it. They used some kind of microcatheter. Later, Ian Han also did some work using rats. But honestly, the suprachoroidal space is extremely, extremely small compared to even like a subretinal or an intravitreal injection. So those are very challenging to do. Peter Campochero's lab actually showed that they were able to do it in a pig and a monkey as well. But a lot of their images were all ex vivo. Again, they also didn't really use a clinically validated microneedle. I think they kind of just tunneled their needle and tried to get it into the right space. So it's hard to know if it was really all in the exact right space. So one of the things we decided to do was to look at non-human primates. Now, why non-human primates? First of all, I study macular degeneration. It's very hard to study macular degeneration in a species that do not have a macula. We can model diseases like wet AMD by doing laser CNV models. And so you're probably all familiar with this. You just do laser injuries to the retina or to the Bruch's membrane to create little breaks and then you can develop these small choroidal neovascular lesions. But if you're trying to study like AMD and drusen, which is what I study, you really need to look at non-human primates. Only primates have a macula. The other differences between mice and monkeys is that mice obviously are 97% rods. They don't really have a cone-rich macula. Actually, if you look at the proportion of other cells, they're relatively similar. They're not a huge difference. But the other big difference is in Bruch's membrane. So in primates and in humans, Bruch's membrane is actually thicker. It's about 2 to 4 micron thick, and it's actually a pentalaminar structure, which we often call, quote, the elastin sandwich, because it's got elastin layer in the middle. It's sandwiched by collagen on both sides, and then by the basement membrane of both the RPE and the choriocapillaris around it. Whereas in mice, it's a much more simplified kind of collagenous layer. It's much thinner, and it might not be as reflective of the pathology that, or the physiology that would lead to AMD pathology. Monkeys actually do develop drusen with age, and they actually prevalence varies from various types of primate centers, mostly because of different age ranges of the animals being studied or different indoor-outdoor status or their method of detection. Monkeys of drusen have been shown to share similar genetic risk alleles as patients with AMD. They also have a lot of the similar components like ApoE, complement factors, vitronectin, et cetera, within them. And some of the first work when I got to my first job, I'm like looking at all these monkeys, was to kind of use my tools as a human clinician to like using a human level OCT and segmentation to kind of compare the retinal anatomy of monkeys versus humans and on histology. And I often do this when I test clinician this, if they can tell the difference between a human or a monkey retina. So I can't really see from the audience from my side, but I'll ask maybe everyone who thinks that the primate, this is the monkey OCT to be on the right. Can you raise your hand? Okay, and then who thinks it's on the left side? Okay, so I can't tell too clearly from my little icon on the screen, but it looks almost like roughly half and half, which is good, which means I fooled you. But in fact, the right one is a human OCT. And actually, you can tell because actually you can see that one of the things I noticed when I first looked at these OCTs is that the difference not so much in the retina, but in the choroid. So if you look at the choroid scleral junction, so this is the junction between the vascular choroid and the sclera underneath. You can see it very clearly in humans, but not so much in monkeys. But instead, in monkeys, you can see that hyporeflective band between the RPE and the choroid, which corresponds with choriocapillaris, whereas in humans, you don't see that as well. And the reason it actually has to do with just the anatomy of the choroid versus in monkeys versus human. It doesn't really take a card-carrying pathologist to see that the choroid of a monkey is really chock full of these really large, darkly pigmented melanocytes, which can cause scattering of light. And so because of that, it blocks the transmission, so you can't see the choroid scleral junction, but it comes up right behind the choriocapillaris, so you can see the choriocapillaris much better. And in monkeys, we actually see these phenotypes that look like drusen. There are some that look like regular drusen, and then there are these also animals that have these tiny little dots that we're still trying to understand. If you do multimodal imaging, you can see that the primates do develop what look like sub-RPE deposits that are reminiscent of drusen. We can do beautiful histology on it. And in fact, you can look closely and see, let's say these are normal RPE cells where the melanosomes are more apically oriented, whereas the RPE cells on top of drusen tend to be more hypertrophic, they're dysmorphic. The melanosomes are all kind of floating everywhere. And if you look at the photoreceptors, however, in monkeys, they tend to be relatively normal. And you can also see on electron microscopy that the interior of these drusen are these little circles that we see, which are very similar to the lipid particles that have been described in human drusen, work from Christine Curcio and her team. We also have basal linear deposits, which are very specific to primates. We don't actually see these basal linear deposits in mouse models, for example, of macular degeneration. Remember, we also talked about those little dots that we see in some monkeys. We've actually gone and looked for them very carefully, and we can't see any bumps or lumps on OCT. And when you look on histology, it turns out that these dots correspond to actually individual RPE cells that are just filled with these kind of lipid vacuoles. So we think each of these single dots are these lipid-filled RPE cells. And we can also see that this actually had been described by Christine's lab in cynomolgus macaques. So we're using rhesus macaques, but she calls this process lipoidal degeneration. So this oil red O staining showing that these dots are kind of individual RPE cells. So the major difference we think between these two phenotypes is that drusen are sub-RPE extracellular accumulation of lipids, whereas this lipoidal degeneration, which is what she called it, or these dots, are intracellular accumulation of lipids. And there's some work from our lab that we're still kind of working on, looking at the impact of systemic lipid levels and circulating lipids on these two different phenotypes. We've been tracking the progression of drusen over time. We can do like nice segmentation, create these nice 3D maps, and we can actually see that they're dynamic. You can see between year 0 and 2, here's an example of a druse that got bigger on the left at year 2, and then the one on the right actually collapsed at year 2. So it seems to be a very dynamic process of remodeling that's occurring. Monkeys have also been used to be tested as a model of inherited retinal disease. My colleague Ala Moshiri and his team had identified the PD6C model of non-human primates. I've also published work using Zika virus and showed that you can actually see ocular defects in a congenital Zika syndrome model. And as I mentioned, that there's also drusen in these monkeys and these serving as models. And so being at UC Davis, I'm doing all this work on all these non-human primates. I decided to try to see if we can inject AAV into the suprachoroidal space. And so that's where I came up with the idea of working with a company that developed it using these 700 micron microneedles and injected into the suprachoroidal space. And we compared it with a standard intravitreal injection versus subretinal injection. And we would look at these animals at a week, a month, and 3 months. Now, immediately when you do in vivo imaging, so this is just a CMV-driven GFP expressing AAV8. And you can see that when you do an intravitreal injection, because this is a native AAV8, it doesn't really penetrate the retina very well, except for a little bit of peripapillary expression. In the middle panel, on the subretinal injection, we actually got really strong expression, probably even hitting some ganglion cells, because you can see those axons going back to the optic nerve beautifully. But with suprachoroidal injections, the AAV is actually mostly peripheral. It's kind of little dots, and it's very widespread. It's actually 360 circumferential. I just can't montage the images from the other quadrant very well because the snout of the monkey makes it very hard to drive the camera to look kind of supranasally. But as you can see, that the expression is very diffuse. Now, one of the reasons why we think that that expression is so peripheral is that if you look at, this is just human cadaveric eyes, and looking at the choroid scleral junction, the choroid scleral junction really is more of a transition zone, kind of gradually between the loose stromal tissue of the choroid to the more compact architecture of the sclera at the bottom. But if you look in the macula, it looks like that. But if you look in the peripheral choroid, you can see that you're more likely to see the choroid and the sclera kind of splay apart. They're more kind of opening spaces. So we think that potentially the suprachoroidal space is a little bit easier to open up peripherally. And that's why when you do a suprachoroidal injection, they tend to travel circumferentially more than more posteriorly. Now, when you look on histology, this is actually a lot of images montaged together. It looks great from a distance, actually. The suprachoroidal injection looks like it's almost circumferential, except for the macula, as I mentioned. But if you're a more astute observer, you can also see that actually the retina, most of that GFP actually is in the sclera, and actually only a small amount is in the retina. And in fact, when you look more closely now at the histology, you can see when we deliver suprachoroidal AAV, it transduced some of the RPE, but we saw there was a lot of photoreceptor damage compared to subretinal injection, where you can actually see beautifully the individual photoreceptors in the outer nuclear layer, as well as the RPE. the other big interesting thing is that when we start looking at expression at 3 months, we saw that the expression disappeared. This was a little bit unexpected. I actually had to like kind of redesign my study because these monkeys are extremely expensive, and I need to see what was going on. So we actually had to adjust the study so that we would take animals down earlier to see what was happening at different stages. And the other thing we noticed also was that these monkeys were developing a unique form of inflammation where instead of just your usual, anterior chamber cell or vitreous cell, we were actually seeing this punctate chorioretinitis. It's a little subtle on these images because there's a little haziness in the vitreous as well, but you can see tiny little dots in the retina and also what we call perivascular sheathing around the vessels. And you can also see on OCT that there are these little hyper-reflective dots on the surface of the retina as well as in the vitreous. And we gave them a short course of oral steroids, and all of those went away after a couple of months. And when we started looking histologically and also on immune system, on the serologies, first of all, I want to kind of break down what kind of inflammation can develop in the eye in response to gene therapy. So of course, there are, of B cells that secrete antibodies. So there's a humoral immune response. And then there's also a cellular response that are caused by T cells. But you can also develop an immune response either to the AAV vector or to the transgene, which is, in this case, GFP. Now, this is a kind of a busy slide, but I'll walk you through at least a few of them. So if you look, we looked on the left side are the antibody responses to either the vector or the transgene. And on the right side, it's the T cell responses. So we did these by neutralizing antibody or binding antibody assays. And on the right, we did ELISpot assays. Now, if you look in the upper left-hand panel, you can see that, first of all, this is a log scale. So with the intravitreal injection, you quickly will achieve a very high dose of neutralizing antibodies to the AAV8 with an intravitreal injection. But the suprachoroidal, it's a dose-dependent increase, but it's but it's not as high as the intravitreal. If you look in the bottom left, if you look at the response to GFP, however, we actually don't see as much response from the intravitreal injected animal, but more response from those that had the suprachoroidal response to GFP. The T cell responses are essentially the same, with the exception of this one outlier animal that because we actually screened these animals previously for neutralizing antibodies, but we didn't screen them for baseline T cell responses. And we're not sure why this one animal had some T cell responses to AAV8. But what we do know is that when we start collecting peripheral tissues, and particularly when you start collecting like the spleen, the liver, and the kidney, we can see that the animal that received the higher dose intravitreal AAV actually had a lot of expression in the spleen. And actually, it's already been shown that when you do an AAV injection intravitreally, it's almost the same as just giving it intravenously. A lot of the AAV particles will egress or exit the eye through the trabecular meshwork into systemic circulation. And that could explain why intravitreal AAV in general leads to more inflammation, because the viral particles are going out into the spleen, to the lymph nodes, where it can trigger greater immune response to the AAV vector. Now, the difference with subretinal and suprachoroidal injections is that, granted, not much of the AAV leaks out into the systemic circulation, and all of the AAV particles are kind of loculated in the eye. But with subretinal injection, if you remember, most of that GFP expression is in the retina, which is within the blood-retinal barrier, whereas with suprachoroidal injection, if you remember that eyeball where everything looks green, but a lot of it is in the sclera, all of that is outside the blood-retinal barrier. We hypothesize that that's why you would get more of an immune response to the GFP transgene as opposed to the vector when we deliver it suprachoroidally. I just realized I have a number of slides looking at the actual inflammatory infiltrates into the eye, and I don't have that slide here, but essentially it showed that there was actually infiltration of both myeloid cells and lymphocytes, and so it's essentially a mixed reaction of many inflammatory cells that we think are being triggered with suprachoroidal AAV injections. Now, obviously, in humans, we're not treating anyone with GFP, and GFP is obviously a non-mammalian gene, so it's very immunogenic. And so, actually, based on our studies and those of others, AbbVie is taking one of their RGX-314 program into humans, injecting it into the suprachoroidal space. And in early studies, it suggests that there was a 70 to 80% reduction in injection rate, suggesting that this may actually be a feasible method of delivery. These are, again, those same swimmer lane plots where each line is a patient, and about half the patients can become injection-free in the early results, with an 80% reduction in annualized rejection rate. None of the patients developed any intraocular inflammation, which is great, particularly with topical steroid prophylaxis. Although they did see some patients with what was called episcleritis or hyperemia. So I can imagine that even though they don't develop the same classic amount of intraocular inflammation, they might develop inflammation in the wall of the eye because that's where the AAV and a lot of the GFP is expressing. I'm going to spend the last 10 minutes or so talking about CRISPR and CRISPR technology. We're all familiar that we're probably already eating apples that have been edited by CRISPR to knock out the iron oxidase genes. And if you think about our current gene therapy strategies, they're primarily protein biofactory. They're just replicating what the drugs do, which is to block VEGF from an extracellular side. It's just that you're using a cell to generate the drug as opposed to injecting the drug. There are some that are using more kind of directed at the RNA, like the 4150, which uses siRNA. But CRISPR is really the only technology that's would theoretically lead to a permanent suppression of VEGF if you can make a permanent change in the genome at the genome level. Most CRISPR systems are bacterial origin. They're part of adaptive immunity designed to cut or destroy foreign DNA. And the most classic case is the Cas9, which is programmable with a guide RNA to make double-stranded breaks in your gene of choice and whenever you make a double-stranded break, you get non-homologous end joining, and you get these kind of error-prone repair of leading to insertion deletion mutations that lead to gene ablation. Newer strategies that don't require double-stranded breaks are things like prime editors and base editors are able to make kind of smaller edits using that technology. So I'll take you through our journey of trying to use CRISPR to try to target VEGF, going from in vitro to mice to non-human primates. Our first study, this is also kind of around the time when I first got to UC Davis. It was like CRISPR was just becoming an interesting area of research at the time. And the first thing we did was just design several guide RNAs to target the first and largest exon of VEGF-A. And we showed that we can ablate the gene using a T7 assay. And then we showed by ELISA that we can suppress the VEGF protein. And we also can suppress tube formation in vitro. So this is an in vitro angiogenesis assay. Next, we developed this into an AAV vector. We injected it into mice. And then we look at it with imaging at week 3 to make sure we got good transduction. And then at week 6, we either take the eyeballs out for deep sequencing and ELISA to look at the amount of editing and protein levels, and also did laser CNV to see if we can suppress choroidal neovascularization. We looked at different orthologs of Cas9. We were looking at the strep pyogenes or SP Cas9, which is the kind of OG, most common, well-established vector. That one you can't fit the guide RNA in the same vector, so we had to split it into 2 vectors, one that expresses the guide RNA and also a GFP reporter, and another one that expresses Cas9. Whereas a smaller Cas9, like Staph aureus or SA Cas9, you can put both the Cas9 and the guide RNA all in a single one. So we thought this would work a lot better. But in fact, actually, it was the dual vector approach that gave us higher rates of editing, higher rates of VEGF suppression, and higher rates of CNV reduction. So the next question is, why cut once when you can cut twice? So why not do 2 guide RNAs. And around this time, we were also starting to think maybe we could potentially take this to a human eye at one point. But we would probably, unlike antibodies that often have cross-reactivity to mice and in humans, we needed to be very sequence specific. So we looked for conserved sequences between mice, monkeys, and human, and we identified the 2 highest scoring guide RNAs. And we essentially tested either the SP-Cas9 combined with a vector with 2 different guide RNAs or one with a single guide RNA, and tested this in vitro and in vivo. And when you look in vitro, indeed, you get more editing when you add a second guide RNA. In fact, if you look at all the blue side, you can get a full truncation or inversions or just standard indels with paired guide RNA. However, when we went in vivo, we actually saw that there wasn't a huge amount of difference actually in vivo by deep sequencing in terms of in vivo editing. And also there was not that much of a difference by CNV area. But what we did find was when we introduced our second guide RNA was that second guide RNA, we did off-target testing with GuideSeq. We actually saw that they were generating some off-target mutations, almost all coming from that second guide RNA. So our data suggests that adding an extra guide RNA doesn't necessarily improve efficacy, but it might worsen your safety. But now knowing what ortholog of Cas9 we want to use, and we want to use a single guide RNA, we decided to take this into a non-human primate study. Again, 3 monkeys, 6 eyes, 12 weeks. And this is what we found. This is a little bit unexpected. But what we saw was that actually when you look at, first of all, you can kind of see very well, especially on the left side here, the shape of the subretinal bleb. We did a really good job. We injected it under surgery into a nice subretinal bleb of AAV. And the first thing you notice is that you get this kind of fingerprint, pattern. And you also have a large deposit of subfoveal hyperreflective material. And there's also this very peculiar regularly spaced thinning of the outer nuclear layer here. What was interesting is that, first of all, that kind of continued to persist through weeks 8 and 12 with progressive loss of the photoreceptor outer nuclear layer. But what was interesting is that we saw this actually with or without the guide RNA. So in our control, it was just supposed to express SP-Cas9, and there was just I think actually it wasn't even a scrambled guide, it was just an empty guide. So we don't think this is an effect because of us editing the VEGF. This is actually just a side effect of the Cas9 itself. We did end up looking at laser CNV. The results were, it was there. It was not super impressive because we weren't having large number of animals anyway. But we did try to explore further what was this subfoveal hyperreflective material. And we did a number of immunohistochemistry, and it seems like a lot of those cells were, first of all, they were pigmented. Many of them were transduced, were RPE cells because they had RPE65. They were often co-expressing both GFP and HA tag. You can kind of see that, suggesting that it actually were co-transduced by both the SP-Cas9 and the guide RNA vector. And there was also just a lot of collagen, and we also did staining for vimentin, suggesting that this was some kind of effect where there's transduced RPE cells, possibly resulting in some kind of epithelial to mesenchymal transition and subretinal fibrosis formation. So in summary, I kind of gave you a really broad overview of everything from gene therapy and gene editing as strategies to treat wet AMD by targeting angiogenic factors like VEGF. We have different modes of delivering AAV. Each of them show different kind of balance between efficacy and safety in terms of reducing long-term injection burden. Non-human primates have a macula like humans. They're excellent animal models for studying AMD and other macular diseases. And then using these primates, we've been able to show that CRISPR-based gene editing can theoretically suppress VEGF, at least in mice, but in preclinical non-human primate studies showed unexpected retinal disruption. And we're still trying to understand the mechanism of that toxicity. I want to thank a lot of the people in my lab. This is over many years of different projects, different grant funding agencies, and of course, all the colleagues at the Primate Center as well. So I'm happy to take any questions.
Thank you so much, Dr. Yu. I have two questions. This was really fascinating, and I learned so much today. So when you compare different injections, uh, the inflammation would be similar to intravitreal when you do intracameral injections?
You're talking about intravitreal versus intracameral?
Yeah, in your PowerPoint, I didn't see intracameral, but people who are
Yeah,
focused on anterior
so
segment.
because I'm a retina specialist, I would say most of the research in retinal gene therapies have been intravitreal, subretinal, or suprachoroidal, but not intracameral. Unfortunately, we haven't done those. I think a lot of those work is either studies involving corneal or glaucoma, or things where you're trying to transduce trabecular meshwork primarily. But we would hypothesize that if we were doing, one thing we haven't really done is actually when we do these intravitreal AAV, is to look for AAV like in trabecular meshwork or iris or ciliary body. I'm 100% sure that many of the current gene therapy programs, as well as many of the current gene therapy preclinical studies, are using just a generic, ubiquitous promoter. So there's no reason to think that they would all just jump over and get into the retina without penetrating into all those other tissues. And that could actually probably explain why there's hypotony in those patients with the intravitreal AAV. But to the extent of whether intracameral AAV, does that have like the similar kind of inflammation? I'm not very well aware of that. But I suspect it
Thank
would
you.
be very similar to intravitreal.
Thank you. Second question I had is that the last gene editing effect you were showing, is it that side effect or bad effects happening because of sustained Cas9? Because you showed even when you inject just Cas9, you are seeing, or is it maybe still viral and mediated, nothing to do with the Cas9?
Yeah, that's a good question. We try to look for, so the question is it inflammation? And, inflammation is a very broad term, right? Obviously, everything we do has inflammation in it. You can probably like poke yourself and there's a little bit of inflammation. So the question is, to what extent is it like truly uveitis? When we start looking at things like we actually did in that paper, we actually looked at things like at least neutralizing antibodies. We looked at cytokines in the aqueous, I think, and we looked at we looked in PBMCs for T cell activity. And we actually did not see much response both in neutralizing antibody or antibodies or T cell response to either Cas9, GFP, or the AAV capsid. It wasn't actually that much because if you remember that experiment was done subretinally. So we actually didn't trigger that much inflammation. And in fact, we didn't see, you remember in the other cases, we're seeing like cell in the vitreous and dots in the retina. These animals didn't have that. In fact, instead, they have this blob of subretinal cells that had inflammatory infiltrates in them. But what we think is happening is that majority of them are actually not inflammatory cells. They're mostly these RPE cells and more fibrotic, right? We saw collagen deposition, vimentin. And so what I think is happening is that subretinal hyperreflective material is just fibrosis resulting from Cas9 transducing the RPE cells, causing some effects that's resulting in EMT. I don't know if there's, EMT is usually a process by which epithelial cells lose their epithelial identity, possibly due to if they're, like in AMD, some RPE cells start to kind of round up and leave the epithelial monolayer. So I don't think it's just the injection effect. I think there's something about the fact that when RPE cells get transduced with Cas9 compared to just GFP, for example, that there's some effect that results in them losing their epithelial characteristics and undergoing mesenchymal transition and causing fibrosis. That's just a hypothesis. We're trying to figure out a way to test these. It's just that this was not the original grant, was not to study inflammation, was to study, CRISPR as a therapeutic tool. But I think that there's a lot to be learned, especially since CRISPR technology in the eye has been tested. They've failed. Editas had the first platform to treat the CEP290 mutation in type 10 LCA, or Leber's congenital amaurosis. And that study had some potential promising results, but then they ended the program prematurely. So we don't have a lot of published data on exactly what happened. And obviously those are human patients, so we don't know what's happening at the histological level. So I think there's a lot more to be learned.
All right, I have a question about the first part of the talk with the RGX trial and the AAV delivery of the anti-angiogenics.
Yeah.
What is the level of expressed protein from those AAVs, and how does that compare to the intravitreal injection? And is there any concern for long-term expressed anti-angiogenics?
Yeah, that's always the big question, right? Like not just for like obviously for my gene editing programs, even a bigger concern. But even with gene therapy, all of these are very, very long-term AAV suppression. So I'll address that question first. When we are injecting when we're injecting anti-angiogenic drugs, a lot of the data does not support the fact that there is a potential negative effect to long-term expression or long-term suppression of VEGF, at least the way we're doing it with intravitreal injection. There's been some hypothesis that maybe you would lead to more like geographic atrophy, and in many, many studies that has not been disproven. Now you can say, well, when you do intravitreal injection, you have these drug holidays, right? You kind of have high dose of VEGF and then you go down, and maybe, that's not affecting the physiologic levels of VEGF. However, if you now look at things like the port delivery system, where they have much more steady state VEGF suppression, those patients actually do very well as well. And so we actually think that it's more likely that you would have, you should worry more about the negative effects of poor compliance and lack of or not enough anti-VEGF or under treatment than over treatment. Having said that, I also want to note that if you look at all of our studies, and even with aflibercept, the suppression is never 100% in these animals. Actually, in mice, it's very hard to, CRISPR is very dependent on which cells are transduced. And then even if a cell is transduced with Cas9 and the guide RNA, it doesn't always lead to a silent mutation. So we think that we can get maybe 30 to 40% suppression only, really, in all of our studies. So we're never like bringing VEGF levels to zero. So the hope is that we're just taking it down from a pathologic level to a more physiologic level. Finally, I think your other question was about difference between the subretinal AAV versus the intravitreal AAV and looking at the protein production levels. So the biggest challenge is that we don't really know for sure because we don't have eyeballs taken out. So all we have is aqueous levels. And in aqueous levels, at least all the intravitreal studies, the easiest, the way to summarize is that is a high heterogeneity in just the protein expression. Like you'll see some people, like if you look at all their papers, the scale is log scale. So there's some people receiving the exact same dose of AAV with very, very high levels in the aqueous of drug, and others with much lower levels of drug. They tend to all be very stable though. So if you look at them over 5 years, like if they started with whatever, 10 to the 12th, nanograms, they would stay that way for the next 5 years. Or if they have a higher dose, if they have a higher production of protein, it would stay at that higher dose. I don't think that the similar types of studies have been done with the subretinal, mainly because the expectation is that a lot of the drug would be higher concentration in the retina than in the aqueous, which is what we are able to sample. So I don't think it's really a apples to apples comparison that you can do, at least unless you have, enucleated eyeballs from these patients to actually test that hypothesis.
And we have one question from the Zoom. Claire Gelfman, are you ready to ask your question?
Oh, hi, Claire.
Hi, thanks for a great presentation. I had a question. You can see in the chat about the utility of including steroids when you do all the non-human primate studies. You can poll 10 people in a room and get half saying yes, half saying no. For the reasons that we want to use it, we could use the non-human primates to learn about the predicted steroid regimen for the human studies. alternatively, there's a lot to be learned from non-human primates that don't get any steroid, because then you really know the raw, inflammatory response. So can you comment on how you weigh those two things when you're designing your non-human primate studies?
Yeah, so in all of these studies, actually in our in the original suprachoroidal AAV studies, we did not start with steroids. We added them when we started developing, because the issue with primates is that the veterinarians sometimes, I feel, take better care of monkeys than human doctors do taking care of patients. They're very, very watching them very closely after these injections. And so any sign of discomfort, they would have called us. And so we had to initiate steroids in those patients. You actually bring a really good point. Actually, we are funded by the FFB to do a study where we are now comparing, looking at non-human primates receiving intravitreal AAV7M8 without any immunosuppression, and trying to do a really clean characterization of what the immune response is. We do see vitreous cell in some of these animals at sufficient dose. We haven't done enough to know how variable that would be between monkeys, but that's one of our main goals, is to compare it without steroids, with steroids, and hopefully with some that are non-steroidals as well, to really, because everyone just say steroids. And I don't think, the uveitis world, obviously there's a lot of, there's a wide spectrum of other of other immunomodulatory therapies that are potentially effective. And so my colleague, Catherine Pepley at UW, at University of Washington, are doing some of those studies in mice. And we're kind of trying to use them to help identify the candidates to then collaborate and work on those in primates. So hopefully we'll understand the different modes, different immunosuppressive regimen, how that would affect the immune response.
Great, thank you.
Hi, Dr. Yu, this is Philip Kaiser. Thanks for a great and super educational presentation. I have a basic question about suprachoroidal drug delivery. So for Xipere, that's indicated for macular edema associated with uveitis. In your study, you show that suprachoroidal tends to target the periphery. So I had it's a little bit confusing. Is it because for Xipere, does it work peripherally to help with macular edema, or does it target the macula because of the pathology?
Yeah, so it's a very, very good question. First of all, the suprachoroidal Xipere, we think that it does go to the back, but I think a lot of it goes to the periphery. So when I say that most of it goes, if you look at the GFP, like 90% of it is peripheral, but there's still some that goes to the macula. I don't want to give the impression that it's like zero goes back there. But we do think that it is much more biased toward peripheral retina than it is to the macula. That could explain why in our, I think the suprachoroidal gene therapy studies right now are working well, because they are all biofactory approaches, right? So it doesn't really matter where your AAV is, as long as it's a secreting drug, the whole eye is gonna be filled with drug at some point. And it doesn't, in a way, it's better that it's confined to peripheral retina, because then you're less likely to worry about any kind of retinal inflammation or any perifoveal atrophy that could occur in the macula, like we're seeing in the RP65 program. Now, how does Xipere work? Because Xipere, we're often trying to treat macular edema. If indeed a lot of the steroids are confined peripherally, how is it treating the macular edema? I actually do think that it is just essentially a very large dose. It's 100 microliters of steroids being confined to this tiny little space. So even the small amount that kind of squeezes back there to the macula is enough to treat. I think that theoretically, especially from the AAV side, if we can develop either different, look at different things like viscosity or, dilute the compound in different types of agents that can help it penetrate or improve the biodistribution to the macula, or to improve better penetration through the blood-retinal barrier into the retina, that could all improve the effectiveness of suprachoroidal delivery. So I think that it's really early. I'm actually surprised they went into humans already, but I think that there's still a lot more to be done that can really help tailor the suprachoroidal approach with proper optimization.
Hi, Dr. Yu. Dominic Lewandowski here. Fantastic talk. I have two questions. First, are there any other risk factors in rhesus monkeys for developing drusen, except for age? And what gene specifically causes them to develop the highest or give them the highest risk of developing drusen? This is the first question. And second, yeah, please go ahead.
No, go ahead. Yeah, so your question is what gene and what risk factors for non-human primate drusen. So that's like the other area of my intense interest, and I'm glad I was able to squeeze a few slides of those into this talk. There has not been a GWAS in monkeys. We've actually done whole exome sequencing on a large number of primates. We can't use the same techniques as in humans, where you have tens of thousands of patients, and but at the same time, the advantage in primates is that the drusen phenotype is relatively homogeneous. Like the ones with drusen, they just look all very similar, as opposed to humans, where there's all these different types of AMD. But we've looked at some number of genes that are already identified from human GWASs, and we found, CFH was associated. Actually, the paper I showed, which was a very old paper from Christine's lab, they suggested arms to HTRA1 locus. We actually did not see that in our association, but we also saw things like ADAMTS9 and some of the other extracellular matrix molecules that are genes that are genes are associated with extracellular matrix remodeling. So we think that that's kind of the genetic profile. We're still kind of trying to clarify some details about that CFH linkage. So it's not published yet, but we've presented it previously. And then the other was the risk factors. So we don't, the only thing really is age. We think that the monkeys they don't develop as severe AMD, like they don't develop GA, partially because of that really dark pigmentation that I showed on that slide with the melanin. So I think, if you compare like a Caucasian to an African American or Asian eye where there's darker uveal pigment, a monkey or a rhesus monkey would be like 10x darker than that, at least. So we're talking about like a whole other order of magnitude of melanin, and melanin in general is not only blocks UV radiation, but also scavenges for oxygen radicals, is an antioxidant itself. So I think that those are protective in monkeys. That and the fact that our monkeys are probably, it's California, so they're probably like getting a kale shake for their diet. So actually, one of our grants right now is supporting us to use a much more Western style, high fat, high sugar diet to see if that affect their drusen progression. And the preliminary data suggests that it does not make a huge difference in drusen progression, but it does seem to affect those little dots that I talked about. So that's a very interesting area of study that we're doing.
Fantastic, thank you. Very quick one. You showed that in rhesus monkeys, the drusen can collapse or regress.
Yeah.
Do you observe or have you heard about something similar happening in humans? And what could be driving it? Thank you so much.
Yeah, so we think that this is, there's a distinction between benign regression and GA formation. We think in humans, when you see a clump of drusen start to collapse, it's not necessarily a good thing. It could be the new onset of geographic atrophy. In fact, we think that's what's happening, is that the RPE is constantly processing all the oxidized lipids from the photoreceptor outer segments. It's also got lipids coming from systemic circulation. And somewhere in that kind of transport, lipids start to accumulate in the sub-RPE space, and that's how drusen form. Now, if the RPEs start to die, then there's nothing making the lipids. So those drusen theoretically can collapse. And that's what we see is when drusen start to collapse, it's often the inception of GA or geographic atrophy. And then that's why the drusen collapse. Now, in humans, I remember talking to Rick Ferris about this at the NIH, and he said that there are a phenomena where you can see drusen collapse and not turn into GA. So they call that benign regression. And that's exclusively what we see in monkeys. We never see GA, we see drusen regression. And we think that that's just because, all these processes are not constant. So there could be change, could be theoretically diet or systemic, there could be metabolic changes or light exposure, anything that can disrupt these, little dynamic changes. So the drusen, some of them get bigger, some of them get smaller at different stages. And so one of the studies we're trying to do now is to do kind of multiomics and maybe even spatial transcriptomics, looking at the cells right over drusen versus those adjacent to drusen to see if there are differences in the gene expression and also a metabolic profile to really understand that process. But we think that it is a dynamic process, although most drusen, like 80% of drusen, are getting bigger usually, and it's a small percentage that are regressing.
Hello. Hi, Professor Yu. That was a wonderful talk. I wanted to switch gears to like the later results. This is Derek Espasio from UCI. So I was curious at these most recent findings. I understand this is a work in progress, but with the result that you see these unexpected effects in the no guide RNA sample, something I wonder about with AAVs, right, is there's a very common use of very strong viral promoters like CMV. And what you're looking at is a bimodal population of transfected and not transfected cells. Do you expect to see this, or in future study designs, will you go after lower expression promoters to see if this is protein burden or overexpression type effect?
No, I think that's a really good question, and actually things that I've also been thinking about. Actually, that might have been aim in a prior grant I submitted that got rejected. But no, I think we definitely should look beyond just your CMV, CBA, CAG promoters. I think all of these promoters are very strong. I mean, we have work from Connie Sepko years ago that showed that these strong promoters generally are more likely to be to cause retinal degeneration compared to, let's say, a rhodopsin or some kind of more physiologic photoreceptor promoter, or just any more physiologic promoter in general. I suspect that even in, let's say, the RPE65 program, I think RPE65, the Luxturna is under also I think it's a CMV, but I know it's definitely a ubiquitous promoter. It's just so happens that AAV2 preferentially transduce RPE cells, but it is generating a lot of RPE65 protein. And so when we're making that much protein, I suspect that RPE cells are not going to be happy. There might be kind of like let's say, unfolded protein responses or other responses to just high protein production that could lead to things like the parafoveal atrophy that we're seeing in some of these clinical trials. So I suspect that our kind of current stage of our development is mostly kind of gene therapy 1.0 of just hitting everything with a hammer. I think we're going to have to get to more refined gene therapies in our next phase of, a lot of people are now looking at more cell-specific or more physiologic promoters. It's just that when you're in an early gene therapy program, you're just trying to get a product onto market. You want to make sure you get your effect. So the same thing with us. I think if I started a program now, I probably wouldn't be using SP-Cas9. I wouldn't be using double-stranded cuts. I wouldn't be using an AAV8. But that was our first time testing this, so we wanted to, go as hard as possible to see the benefit. Now I think it's time to become more refined in our development.
Hi, this is Hewlett from the Piante Lab. My question, to follow up on what you were saying, when targeting VEGF and the EMT that's observed, do you observe this when delivering RNP or?
So that has not been reported. So I think that could be potentially a much better effect. Like a lot of even the Editas, I think the first in-human trial was also a ubiquitous continuous promoter making Cas9, but as you astutely surmise that you don't need, you can just inject RNP directly, and because you only need to make the edit once and then your effect is done. Or some kind of kamikaze or self-destructing AAV design. I just personally haven't done a lot of work with RNPs themselves, but looking at published data, that has not been shown to cause the same effect. In fact, we've also looked at, there are other people doing CRISPR in in either humans or in monkeys, and this has not been reported in other platforms. And we're still trying to figure out what is the major distinction. We were looking at, like, let's say AAV. Is it the type of AAV? Is it our promoter? Is it our construct? We don't really have a good explanation for it. I mean, these results, we just published this last year, and we're still trying to see if we can get funding to further understand kind of this Cas9 associated toxicity. Although I feel like it's probably easier to get funding to look at what would work as opposed to trying to understand why this didn't work, even though I think it's still an important question to answer.
Hi, Dr. Yu. Thank you so much. It was a fantastic talk. So I have two questions and I'll be brief. The first one is about this NHP models, and you mentioned that they have different formation of drusen over time with aging, but the overlying photoreceptor layer and the choroidal thickness seems to, the PR seems to be physiological, and the choroidal thickness is still increased compared to what you would expect from humans. So does that affect your readout when understanding the treatments for drusen therapy or for just regular NMD treatments? And then the second question is more about the latter presentation. When you were talking about injection of AAVs of the gene editing construct, and you described the RP transition more into fibrotic state and EMT, does that raise concerns for you regarding the oncogenic potential of these? Because we do know that EMT can be considered a pre-malignant state and also associated with the Cas9 independent side effects that arrange like chromosomal abnormalities or even chromosomal lysis. Does that raise concerns for you? So yeah, that's certainly. All. Thank you.
For the second question, I think certainly that there is a concern, and I think that's one of the reasons why I feel like we need to do more studies to understand why it's undergoing that fibrosis. And I think that, I don't really think about subretinal fibrosis as a tumor, but I guess it is. But it's more, we usually think about it in the context of, let's say, in retinal detachments, where you can get a lot of scarring that can lead to, or even in AMD, where there's long-term, choroidal neovascularization can lead to subretinal fibrosis and scarring, and that can lead to kind of long-term vision loss. So I think I think that is an area of concern, which is why I think we need to better understand the role of subretinal delivery of at least using a CMV promoter to drive SPCas9 in the primate eye. The first question, I don't think I completely understood. Are you talking about, because you were talking about drusen and choroidal thickness or something like that? What was the question?
So it was about, you see that although you have formation of drusen in NHP models, the overlying PRs are still physiological, and you have that choroidal thickness. So I wonder if when you do the readout of these models, if you observe perhaps choroidal thinning, or you observe any sort of readouts of the treatments, since you have that.
Yeah, so we are not, we haven't done any treatment studies on the drusen animals. I actually see Martha Nuringer's on the call, so she's actually done a lot more work with drusen and using different type of dietary intervention. We've actually been just trying to characterize it and actually make it worse to see what are the potential risks that can make drusen get worse. We can't measure choroidal thickness easily. We've actually published a paper on this. We can kind of measure it. We actually looked at things like choroidal vascular index and choroidal thickness. In monkeys, actually, if anything, the animals with drusen have maybe slightly thicker choroid. And there are actually subtypes in human AMD where drusen there's something called pachydrusen, where the choroid is a little thicker and actually compresses the choriocapillaris, leading to impaired outflow and kind of a different mechanism for drusen formation. So we see that in some of the monkeys, but because the choroid-scleral junction is so hard to delineate because of the shadowing from the pigment, it's hard to get really concise measurements. So we haven't really done a lot of extensive studies looking at the impact of the choroid on drusen in vivo in monkeys. Certainly, we're really interested in taking these eyeballs when these animals die to do things like spatial or single cell transcriptomics to understand the role of the choroid in primate drusen.
Hi, Dr. Yu. This is Alex from Dr. Palczewski lab. I have two questions. First about your suprachoroidal injection. So was the choice of your AAV serotype dictated by some kind of screen, or do you expect that different serotypes would have some kind of different tropism to, let's say, to better transduce the retinal cells or RP cells? And my second question actually is very naive, and I'm not a clinician, so apologies already for that. But I was just wondering, when you do subretinal injection and you achieve this kind of detachment between the RP and retina, what is the actually the effect of this detachment itself on the visual function? And how does it, is it benign or does it somehow harm the?
Yeah, so two both very good questions. The first one is why do we just use AAV8? We used AAV8 initially because in our pilot study we had nothing. We didn't know what AAV would work. We knew that between the at least the general serotypes, AAV8 in our hands actually had we could achieve higher titers. We can get, it has most types of cells could be transduced with AAV8, at least when given subretinally. So because of that, we chose that vector as our first test in the suprachoroidal space. I think other people have also tried AAV8. I know Ian Han from Iowa had tried a variety of different AAVs, and but they only tested in rats, and so I don't know if if it translates well, but they've shown that there's some differences between different AAV serotypes. The most interesting would be to try to do directed evolution within the suprachoroidal space. So that's one of the things that we're hoping to do in future years. And I know it's already being pursued by Regenex Bio, the company. And that has been presented at ARVO, I think last year. With regard to your second question, sorry, what was the second question again?
Oh, just the effect of the detachment of the retina from the RP.
Yeah, so we know in general that if you just inject, let's say saline into the subretinal space, the retina will reattach. Generally, there's uveal scleral outflow, and the RPE does kind of have a slowly pushes water out from the subretinal space into the direction of the choroid. So that's how when you inject a bleb, it goes away within probably 24 hours. And so that effect itself probably does a little bit of damage to the retina, especially if, let's say, you can imagine shear forces that can cause some damage. We haven't seen significant, I don't think that there are significant ERG changes. I don't know if anyone's, I'm sure that study has been done or some control has been done where there's no significant photoreceptor toxicity to our knowledge compared to the AAV. But I'm pretty sure when you do a subretinal injection, there is some small amount of damage that can occur. To the extent of whether it would affect vision in the long run, I think it's a risk-benefit ratio. So I presume if you think your therapy adds that much benefit, the small amount of damage just from creating a subretinal bleb is probably not a big problem. I guess one of the advantages of, let's say, these biofactory gene therapies, that many of them we do these injections outside of the macula, so that essentially the drug generating cells are outside the macula. So even if there is toxicity, it won't manifest in central vision.
Hi, Dr. Yu. Thank you for your wonderful talk. Mine is just a curiosity. Does the degree of VEGF gene ablation correlate linearly with the level of protein suppression? Or maybe there are regulatory mechanisms that can influence?
Yeah, it's, just the question is there's no easy way to measure VEGF levels in the tissues aside, especially in humans, we're usually just taking aqueous and rarely vitreous taps, but it's not like we know what the VEGF levels are in the retina. So there are a lot of factors that could affect this. It could be that even with intravitreal drugs, there's a lot of heterogeneity and variability in measured VEGF levels with or without the drug. So I just don't think that that question can be answered easily. We know that there's variability between people and the amount of VEGF in the aqueous. It does not always correlate with disease severity. It doesn't correlate necessarily with how with treatment effect with anti-VEGF. And then now with gene therapy, we see, the data is unclear whether the patients with the highest drug level being produced are necessarily the patients who are injection free. So I think there's a lot of heterogeneity, and that's what's making these studies a little bit hard to interpret.
Very much. So let's just finish with two last questions because Dr. Yu has to go back to clinic and cure blindness.
Thank you.
Yeah, thank you. Thank you for that stuff. I'm JT Kim from South Korea. I'm visiting scholar, vitreoretinal specialist too. And you show the benefits of the suprachoroidal injection for gene editing, gene augmentation therapy. So there's some big vessels, large choroidal vessels. So I think the fluid there can be easily observed. So can you comment on the half-life and the immune reaction of the procedure?
How much of your question, I heard something about large choroidal vessels, and then you're also asking about the immune, how to monitor the immune.
Yeah. That the AV up there can be easily observed. So I think it can cause systemic immune reaction. So
Yeah.
can you comment on?
First of all, the question, I guess two things. Number one is when we are injecting the suprachoroidal space, how much of these are actually getting into the choroidal vessels? I actually don't think a lot of it is getting into the choroidal vessels themselves. It's not like we're, cannulating vessels. We're just kind of injecting it into stromal tissue. Now, it's possible that your needle will hit choroidal vessels and some of it will get, into the choroidal circulation and out, and out into the periphery. But I think majority of these, we suspect that most of this bleb of fluid is in extravascular stromal and extrastromal space between the sclera and the choroid, and maybe a little bit oozing into the choroid and oozing into the sclera too. Now, in terms of inflammation, I actually do think that having AAV within the choroid, which is outside the blood-retinal barrier, there's macrophages there, and also in the scleral wall is going to be immunogenic. The main question, I think, when we start thinking about the clinical setting is whether that immunogenicity is enough to cause adverse clinical effects or adverse outcomes. And if indeed a little bit of, if the eye is a little bit pink, and if it's a low grade of inflammation that is not going to cause a big problem in terms of eyesight and outcomes, it might not be a problem. If it continues to trigger, like let's say we haven't even talked about second eye treatment, right? Like if you inject this AV in one eye and you start revving up the immune system, then you get a treatment in the other eye could have potentially a maybe stronger immune response or reduce treatment efficacy if the immune system starts to remove transduced cells. So I think that there's a lot to be learned that we still don't know yet. But those are all the things that we can think about. But I definitely do think that suprachoroidal delivery does have its own type of immunogenicity, just not the same way that we expect in intravitreal.
Dr. Yu, thank you very much. This is Andrew Brown at UC Irvine. Really fascinating talk covering a lot of really interesting challenges in the field. And I think we've had a lot of questions about suprachoroidal delivery because it's a fairly unknown area for a lot of us. But my question is, do you think that there are ways that one could essentially prime the suprachoroidal space before injection? And there's maybe elevating central venous pressure, or maybe even expanding or contracting the choroidal vascular volume with osmotic agents to try and enhance the posterior spread of the injection rather than circumferential spread. Thank you.
I have not thought about some kind of priming agent, but that's a good idea. We have started to look at just very basic stuff like changing intraocular pressure and then also increasing the injection volume. And they all definitely have effects in the spread in the suprachoroidal space. Right now, we're doing some studies using just like ICG because it actually have very long wavelength. We can see through the choroid despite all the melanin with it. So we're trying to understand that, but we haven't thought about priming it with like another, like maybe injecting with some viscode or something to kind of create a space first and then injecting the drug, the AAV or the drug afterwards. We haven't thought in that sense yet. I mean, the problem is that most of the companies want like an easy, just stick the needle in and just squirt. So the more steps you're thinking about, the less potential clinical application there is. So, but I think some smaller modifications, like maybe in the carrier or the vehicle, and potentially the volume, I think those are easier things that we can manipulate.
Thank you very much. It was wonderful, a wonderful discussion, a great presentation. Let's join me and thank our speaker.
Thank you, everybody. Have a good rest of your day.